Hi, my name is Lindsay Hilmer, and I'm a PharmD candidate currently on acute care rotation in Des Moines, Iowa. Today, my presentation will be looking at the management of blood glucose in critically ill internal medicine patients with diabetes. The presentation today is based off of my references, and all of the opinions stated are my own. What I would like you to get out of today's presentation is to understand the physiology of blood glucose changes in critical illness, review some clinical trials related to inpatient glucose control, and review what the current guidelines state for inpatient blood glucose. In acute illness, such as an infection in the body, it's stressful, and in response, the body releases various hormones to help protect vital organs like the brain. Epinephrine, cortisol, and growth hormone are released in an effort to maintain blood glucose. They act on the liver to stimulate glucagon release, increase glucose production by the liver, and peripherally stimulate lipolysis. Epinephrine also inhibits insulin. In addition to the body attempting to regulate blood sugar, medications are commonly given to patients during acute illness that impact blood sugar. Some that I've seen recently on my rotation include vasopressors and glucocorticoids. It's important to keep these medications in mind for patients with an insulin regimen because their needs may be dramatically increased while on the medications, but if the therapy is complete, then the insulin will need to be adjusted further. So in the last 20 years, there have been numerous studies done in an effort to describe how blood sugar should be managed in hospitalized patients. Going back to 2001, the intensive insulin therapy in critically ill patients study enrolled surgical patients and compared intensive insulin therapy, so blood glucose 80 to 110, to conventional therapy being 180 to 200. And found reduced morbidity and mortality in the intensive insulin group. In 2006, the same investigators did a similar study, but with medical patients. It was again found that intensive insulin therapy was preferred over conventional therapy. However, it was also found to benefit morbidity, but not mortality. Both of those studies were done in a single center, which even the authors describe as a limitation to the studies. NICE Sugar in 2009 is a large multi-center international study that focused primarily on 90-day mortality with various levels of glycemic control. They found intensive glucose control increased mortality among adults in the ICU, while the blood glucose target of 180 milligrams per deciliter or less resulted in lower mortality than the target of 80 to 108 milligrams per deciliter. Also in 2009, GluControl was a large randomized control trial trying to answer the same question. The study was stopped early, however, and its limited results did show an increased risk of hypoglycemia in the intensive insulin therapy group, and there was no benefit on mortality. NICE Sugar appears to have been one of the driving forces for the change from intensive insulin therapy to higher goals during hospitalization, mostly because of this now well-established link of hypoglycemia leading to adverse outcomes. Since the NICE Sugar study in 2009, multiple studies have been done, now more focused on glycemic variability. I linked a 2020 study that was done in Thailand that looks at whether or not glycemic variability affects mortality, and they did find that a larger variability led to higher mortality rates. The future of inpatient glucose control may include newer technology like continuous glucose monitors in order to achieve better control over blood sugar. But at this time, more studies need to be done with larger patient populations. That we've gone over some of the major trials for describing blood glucose goals in hospitalized patients, I wanted to look at the guidelines to see what they have to say about it. The 3 guidelines I chose to dive into were the American Diabetes Association, Society of Critical Care Medicine, and the American Association of Clinical Endocrinologists and American College of Endocrinology. So as you can see, all 3 of these guidelines have similar blood glucose goals recommended. So the American Diabetes Association recommends a goal of 140 to 180. Now, keep in mind, this is specifically for critically ill patients. The goals may be slightly different if a patient is hospitalized but not critically ill. IV insulin is the preferred management for critically ill patients with hyperglycemia. And one of the main things I pulled out of their guidelines is that it discourages the sole use of sliding scale insulin, which I feel is a practice I've seen in quite a few of my rotations. The Society of Critical Care Medicine, this guideline is from 2016, just looking at the general ICU patient. More specific patient goals like surgery might be different. The Society of Critical Care Medicine specifically recommends the goal of 150 to 180, while Aspen recommends 140 to 180. This guideline didn't really look too much into how these goals are treated, but more so looking at this as a whole when taking care of a critical care patient. And then the AACE, ACE guidelines, again, is 140, 180. They also recommend IV insulin for ICU hyperglycemia. Again, the exclusive use of sliding scale insulin is discouraged. And then one thing I really liked about their guideline is that an A1C is recommended to be checked if it hasn't been done in the last 3 months, because this can help determine how difficult it's going to be to manage a patient's blood glucose. They also mentioned the glucose variability, which, like I said, in the last 10 years or so has become more of the driving factor for future studies for controlling blood glucose. They do not give a specific range to target other than the 140 to 180, but it just recommends minimizing that glucose variability. So given the trials that I looked at and then the guidelines discussed, I made some conclusions for my pharmacy practice moving forward. First, when a patient is hospitalized who has diabetes, make sure to find the most recent A1C for that patient, if possible. And if it hasn't been checked within the last 3 months, recommend that that gets rechecked. Furthermore, recommend basal bolus insulin instead of sliding scale alone. It's pretty clear through both the ADA and the AACE, ACE that sliding scale should not be used by itself. For patients that are having hyperglycemia, so blood sugar is above 180 consistently, we may want to suggest IV insulin. I know a lot of providers are kind of wary of the IV insulin, but a lot of studies have shown benefit in controlling blood sugar with that higher goal in mind of 140 to 180. So that brings me to the last point of adjusting insulin to keep blood glucose within that range of 140 to 180. That brings me to the end of my presentation. These are my references. Thank you for following along if you made it here. I've really enjoyed putting this presentation together, and this is definitely a very interesting topic to me. I hope to do more research in the future on specific blood glucose goals in various patient populations. Please feel free to comment any questions or concerns you have about this presentation. Thank you.